Thank you, Namal, and good morning to all the participants and resource persons. And thank you, Sepsis Alliance, giving me the opportunity to address on rational antibiotic approach in sepsis. So, management of patients with sepsis, we have already discussed from the morning. So, it is giving a good airway, fluid oxygen supplement, good IV access, and required cultures, and source control, and of course, antimicrobials. So, sepsis, is it really sepsis? Always. It could be real sepsis, but sometimes, about 1/3 of the cases, it could be non-infectious condition, looks like sepsis. So then, of course, we have to continuously assess the patient to determine the possibility of other diagnosis, because otherwise we'll be just wasting time and resources. So how to approach rationally? So main thing is early broad spectrum antimicrobial selected rationally. We will talk why selected rationally later, and optimize the dose, and stepping down with available cultures, and omitting when not necessary. These are very important. So when you suspect sepsis, you have to start broad spectrum antibiotic. So what do you consider when you start this so-called broad spectrum antibiotics? You have to consider likely site of infection, because not everything will not cover, anything will not cover everything. So you have to have the likely site of infection, and you have to consider about the prior antibiotic exposure of the patient, and local antibiogram, because the sensitivity will be different from different hospitals, and comorbidities of the patient, severity of the condition, and allergic history. And then, of course, we have to optimize the dose with aggressive loading dose, and adjusting for obesity, renal function, and other condition of the patient, and giving prolonged beta-lactam infusions. So, what do we call by likely site of infections? We have to, if possible, not always it's possible, but search closely for symptoms and signs of infectious source. It could be the patient must have started with a productive cough, giving possible pneumonia, and it could be purulent exudate from surgical wound or catheter site. It could be urinary symptoms. It could be skin lesions. It could be abdominal tenderness or guarding, or it could be meningeal irritation, because each and everything will require different type of antibiotics, but it does not, the giving same thing to all these conditions will not be very helpful, and it is not rational, of course. Then we have to reassess after urgent intervention, because sepsis, as we have discussed already, it's urgent. We have to attend urgently. So after urgent intervention, we have to reassess continuously. So if you take few examples, like productive cough, history of productive cough, suspected pneumonia, it could be community acquired, it could be hospital acquired. That much we know, of course, when a patient comes. So if it is community acquired, our drugs of choices will be ceftriaxone or cefotaxime with clarithromycin. And if the patient, now at the moment, like we are having influenza in the country, so we have to consider that as well, because unless we have all the investigations available, it's not possible, like at least CRP, white cell count and all, we might have to add oseltamivir if we suspect influenza, if it is an influenza kind of season. And we have to consider vancomycin if we suspect MRSA. Why we suspect MRSA, we will discuss later. And if it is hospital acquired, patient comes from another ward to the ICU, sort of, we have to consider always pathogens, multi-drug resistant pathogens, which can cause hospital acquired pneumonia or ventilator associated pneumonia, where we have to start something broader. It's not because in community acquired pneumonia, what we cover, strep pneumonia, atypical pathogens, and viruses. But in hospital-acquired, we have to consider the hospital pathogens, which could be any, like coliform, it could be Pseudomonas, it could be Acinetobacter. So we have to consider local antibiograms as well as whatever available previous cultures to guide us to start the correct treatment. So, even in community-acquired pneumonia, if you suspect melioidosis, of course, then we have to start with meropenem, because melioidosis, Burkholdidium pseudomele is not covered with bauceftriaxone, cefotaxime, and clarithromycin. But it's not always, but you can guess if the patient is from rural area with paddy involvement and a diabetic patient, sort of, and with the condition, you can guess whether it is normally community-acquired pneumonia or whether it is suspected melioidosis. And another example, urinary symptoms. If the patient comes with urosepsis, then again, we have to consider previous cultures, whether the patient has been in the hospital for a while, and so a few things. But most of the time, pathogens are gram-negatives, very rarely enterococcus or staphylococcus. So we have to cover gram-negatives, which can be covered with piperacillin tazobactam plus minus aminoglycosides such as gentamicin or amikacin. And if the patient has a history of, like, patient comes with urology ward, especially with stenting and all, then of course we have to go a little beyond that, maybe meropenem and or imipenem as the initial treatment during the first stage. If the patient comes with abdominal sepsis, I have taken very few instances, peritonitis due to ruptured appendix or anything, biliary sepsis or post-surgical abdominal sepsis. Here again, the most common pathogens are gram-negatives, rarely enterococcus, so that we can treat with piperacillin tazobactam plus minus gentamicin, or if, as I said, post-surgical abdominal sepsis patient has been in the hospital and has undergone reopening and all, then of course we have to think about more resistant organisms such as meropenem. Because normally if the patient comes from the community, our gut organisms are most of the time, if we behave well, so they are sensitive. Like they can be killed with simple cefuroxime. And if the patient comes with meningeal irritation, where you are not very sure yet whether it is meningitis or encephalitis, neonates, of course, encephalitis very rare. So neonates, we have to cover the pathogens, possible pathogens, like because they are different in different age categories. In neonates, thinking about the pathogens like E. coli, Listeria, and group B streptococcus, the drugs of choice will be ampicillin and cefotaxime. But 1 month to 50 years, the common organisms, pneumonia, Haemophilus possible to some age, and Neisseria meningitis are common. So where you can give cefotaxime and or ceftriaxone plus vancomycin, because our Streptococcus pneumoniae is shown to be resistant, not always, but we have resistance to cefotaxime. But we don't treat alone with vancomycin, but we add vancomycin to cefotaxime or ceftriaxone. As you can see that because we don't want, it's not indicated to start meropenem at all in this kind of situations. And of course, again, if you are not sure whether it is meningitis or viral encephalitis, plus minus acyclovir. Above 40 years, we have, again, we are going to address Listeria. That's why we have added ampicillin to the group when we treat with cefotaxime plus vancomycin, plus minus acyclovir, ampicillin to cover Listeria. So this kind of approach, given by all the guidelines, it's very rational, and it's what we can treat the patient successfully. Another example, skin and soft tissue infections, most of the time, Staph aureus and Streptococcus pyogenes. So unless you suspect MRSA, you can treat with piperacillin tazobactam with clindamycin, both have gram-positive good cover and antitoxin cover. And if you suspect MRSA, you have to add vancomycin. These are from new guidelines, which was mentioned by the previous speaker, national guidelines of empirical and prophylactic use of antimicrobials, 2024. And we most of the time we don't know the focus. That's what it comes when sepsis and bystanders don't know whether the patient had any problem at home. We can guess whether it is community acquired or whether it is hospital acquired. And according to our guidelines, local guidelines, if the patient comes from the community, because most common etiology would be the conditions I have already mentioned. So cefotaxime or ceftriaxone plus gentamicin and plus metronidazole to cover anaerobes would be good. But if you think the patient is severely septic and when you have no clue, of course, we can start with meropenem because we have no time to lose, because it's better to de-escalate later than losing the chance. So if it is hospital acquired, of course, we have to think about all the resistant pathogens depending on your institution. Choice of antibiotics. So we have talked about likely site of infection. And then, of course, prior antibiotic exposure, we have to consider resistant organism because, as I said, UTI patient comes from the urology ward, always alarming because they have undergone so many procedures and investigations where the most common pathogen would be not simple sensitive E. coli or Klebsiella, could be some resistant Pseudomonas, vancomycin resistant Enterococcus, and so on. Local antibiograms, and we have to consider local antibiograms will be available with you. And comorbidities, we have to consider diabetes, CKD, and sort of, and severity of the condition. And of course, allergic history, not to have, as the previous speaker said, we don't want anything else. So this is a cumulative antibiogram where you can see your sensitivity patterns to guide you the treatment and whether to start MRSA or not. You have to think again whether the patient was having MRSA exposure or MRSA history or in your institution. This is a simple sensitivity pattern of Kandy Hospital, ICU for several months. We had 31 isolates of gram negatives with sensitivities of 52% of and 54% of amikacin and meropenem. As you can see that we don't have 100% sensitivities. These are the things which will guide us. And regarding gram positives, we too had in the ICUs a good number, about 19. So we have 34 gram negatives and gram positives. So when the patient comes to the ICU, in our situation, we have gram positives, negatives 59% and 41 gram positives. It's better to cover Staph aureus, MRSA as well, because it all depends on your institution. So empiric treatment, targeted, suspected, we have to suspect the sources. Within 1 hour, we have to start. And aggressive first dose and prolonged beta-lactam antibiotic infusions. And then, of course, tailor, narrow down and discontinue. Loading dose to achieve the effective beta-lactam concentration, we use like double dose kind of meropenem 2 gram because it clearly gives the very good concentration above MIC for a longer period. And then, of course, continuous infusion of beta-lactam shown to lead a better bacterial eradication because it gives above MIC for a longer period when you give 1 gram over 8 hours of meropenem example. So double gram negatives shown to be not very superior, but in our guidelines, they have in sepsis and they have advised. So and de-escalation to mention, we have to de-escalate when the cultures are available, and duration and discontinuation of antibiotic when we have adequate source control with improved clinical outcome. We can use procalcitonin to stop antibiotics because we don't have clear-cut durations. So with the procalcitonin, we can omit antibiotics. So antifungals, of course, if there are indications, we can start. So I had a case, but then we don't have enough time. So that's okay. So, and take home message, rationally select early broad spectrum, not meropenem and vancomycin for all the patients. You have to choose and select, optimize the dose, loading dose, and continuous infusion when indicated, and stepping down with available cultures, omitting when not necessary. Thank you.